Okay. Good morning, good afternoon, and good evening, everyone. Welcome to the thematic room number 3, the Pediatric and Adolescent Service Delivery. And my name is Dr. Twitya Sucharitrak. I'm a pediatric infectious disease specialist working at the Faculty of Medicine, Chiang Mai University, Chiang Mai, Thailand, and also a past CIPHER grantee in the year 2014. And today is my pleasure to be a facilitator of this room. For the housekeeping rules, in this session, there will be 3 presentations of 8 minutes each. After the presentations, there will be around 30 minutes for Q&A. So please feel free to send your question into the chat function or verbally ask the question to the speakers by raising your hand and waiting for me to give you the floor for asking the question. And if you have the questions directly at one speaker specifically, please.
They just told me day before yesterday night now.
So please be brief when asking the question. And right now you are all mute, but we will go over how to unmute yourself and how to ask.
I'm just
So you are all mute right now, but we will go over how to unmute yourself and how to ask the question when we arrive at the Q&A session. Please keep your camera off, and we will record this webinar and will save the chat. So when you ask the question, please kindly indicate your name and contact details so we can share the chat with the speakers at the end of the webinar, and they will be able to follow up on your question in case that they do not have the time to address it here. So today we have 3 CIPHER grantees. First, Dr. Elona Toska from South Africa. The second, Dr. Sirinya Teeraananchai from Thailand. And the last speaker, Dr. Merrian Brooks from Botswana. I'm now leaving the floor to our first speakers, Dr. Elona Toska. Please.
Good afternoon, everyone, and good morning and good evening for colleagues from all the other time zones. Thank you for joining at the start and at the end of your days. I hope everyone can hear me, and if you could move to the next slide, please. The next one. Today, I'll share some data from my CIPHER supported research on access to HIV and health services amongst adolescent mothers living with HIV and their children. And I'm presenting on behalf of a large team based in the Eastern Cape province of South Africa called Hey Baby, which stands for Helping Empower Youth Brought Up in Adversity with Their Babies and Young Children. Next, please. The specific focus of my CIPHER supported analysis and work was to understand how we could improve retention in PMTCT and ART care for HIV-infected adolescent mothers and their children, and specifically to look at whether there were health services linked to adolescent mother outcomes and children outcomes. Next slide, please. First, just an overview of who the adolescent mothers living with HIV in our study were. We were able to interview 293 adolescent mothers living with HIV and their children, and you can see that just over half of them had their first child before the age of 18. 25%, a quarter, lived in rural areas, and another quarter in informal housing. A large proportion of them, nearly 4 out of 5, just over 4 out of 5, lacked one of 8 basic necessities. So 3 meals a day, enough money for clothes, or to go visit the doctor and buy medicine. And just over, sorry, there's a message blocking my screen, but just over 28% did not have enough food in the past week for 3 meals a day. And a third of them were not in school even a year after they had given birth, which is usually a timeline by when we hope that they would have returned. In the next slide, please. Next. Thank you. We tried to understand a bit what was happening with first accessing ART care for and PMTCT specifically for adolescent mothers living with HIV. And this is all self-reported data, which we are hoping to triangulate with data from their patient files and the National Health Laboratory Service in South Africa. But 6% never actually started ART care. 34%, a third of them started after the end of the first trimester. And of all those who started, 1 in 10 stopped taking their antiretroviral. So altogether, combining the 6% who never started and the 1 in 10 who stopped, we have about 1 in 5 mothers that are either not accessing care or, apologies, I am getting phone calls. Just turned it off, apologies. We have about 1 in 5 adolescent mothers that have inconsistent or completely interrupted care. In the next slide, we can see a bit more details about what their treatment access looked like. So specifically, we can see that when we're looking at past week adherence, adolescents HIV, but we're not mothers. When we looked at treatment interruption, so this is interrupting treatment for multiple days and up to a month in the last year, you can see that adolescent mothers living with HIV were more likely to have actual treatment interruptions. And this was also reflected a little bit in viral load data available. This is a smaller subsample that we've been able to match so far, but what was clear from this data is that once adolescent mothers living with HIV have viral load data, only half of them actually had it, they seem to be doing okay when it comes to similar rates of viral suppression. But they're actually much less likely to have viral load data compared to adolescent girls living with HIV, suggesting potentially some disengagement in care. In the next slide, we looked into a little bit more of the treatment-related experiences. So we heard from adolescent mothers that 13% found it hard to take pills while in relationships. They're also more likely to be in sexual and romantic relationships, either with the fathers of their children or with new partners. 14% reported that they found it hard to adhere to the medication because they had drunk alcohol in the last week. We also heard them telling us that they also struggled with substance use. So a quarter of them actually drank enough or took enough drugs to not be able to walk or remember what happened the last time that happened. So quite excessive substance use, not sort of the glass of wine or beer that we may have socially. When we look at the actual treatment experiences, we see that the majority of adolescent mothers living with HIV are on single pill regimen. And this is also reflected in having started antiretroviral therapy recently, which is not surprising because for many of them, starting antiretroviral therapy and finding out pregnancy seems to overlap, and that's an important moment. We've started doing some more advanced multivariable analysis to look at which factors were associated with poor treatment outcomes amongst adolescent mothers living with HIV. And this is looking at both treatment interruptions and past week non-adherence. The viral load data is not yet fully matched, so we're just working with NHLS to complete that. And we see that 4 factors are emerging. Stockouts, not being able to get their medicine when they go to the facility, being treated, not being treated well or respectfully, so being shouted at by clinic staff for missing pills or for having sex, and the stigmatizing of these behaviors, feeling dissatisfied with how they were treated at the facility when they last visited, and being in inequitable relationships. So in relationships where they are unable to negotiate taking treatment or using condoms and other protective measures. In the next slide, just before finishing, it's some new data that this is currently under review. So it may change a little bit with feedback from peers, but we tried to actually look at what were factors associated with secondary HIV transmission, which we defined as the overlap of non-adherence or viral activity, viremia, and unprotected sexual practices, or so sexual risk, because that is really where young people, it's at the overlap of the two that secondary HIV transmission may be happening. And we see here two lines. The green line at the bottom is adolescent girls living with HIV who had not yet had children, and the purple line is adolescent mothers living with HIV. And for all the risk factors at the bottom, the risk level, these are percent probabilities in marginal effect modeling, is higher amongst adolescent mothers living with HIV. Individual risk factors account for quite a bit of risk, and these are, again, inequitable power relationships, past week hunger, excessive substance use, and being recently or sexually infected. And at the top right, we see that the adolescent mothers that experienced all four of these risk factors had 89% risk of reporting HIV transmission risk, and two partners or their children. And this would be quite important factors to screen for when we're thinking about how we can adapt or support adolescent mothers in routine HIV care. Some of these may be easier factors to screen for than others, but we generally have in our folders when mothers got infected in terms of timing of ART initiation. There is evidence that one can screen for substance use in some settings, and we certainly could ask about hunger, which would be an easy marker of potential risk. In the next slide, a quick overview on the children. We see that the majority of the children of these mothers were quite young. We're collecting new data in these post-COVID days in South Africa in the second wave, so very heavily COVID days. But what we know from the baseline in 2018-19 is that if you go to the next slide, please. 91% went to the clinic for an antenatal care checkup in the first trimester, but only 15% of them went to 4 or less clinic appointments. And in South Africa, during the study, the requirements went from 4 clinic visits minimally during antenatal care to 8 during this period. So we're still trying to figure out how to best see if they met minimum antenatal care criteria. But perhaps a clearer marker of access for the children of mothers is percent of children that were fully immunized. And we see this sadly dropping from an already very low 37% at 6 months to much lower at about 17% in 18 months. Some of this was marked by a shortage of hepatitis B vaccination, but even without that, the rates are even lower of full child immunization. Are just slightly higher of full child immunization. In the next slide, it's the experiences of breastfeeding and access to treatment amongst the children of these mothers. And we see that just under half, 4 out of 10 young mothers exclusively breastfed their children in the first 6 months. But that was at least better than the mothers who were not living with HIV. And we see that 1 in 5 stopped breastfeeding at just under 6 months. Amongst the children, we see relatively high rates, 87% who had tested for HIV, but amongst those who have tested, 5% had at least 1 HIV positive child, which is as of now about 3 times the maternal to child transmission rate in South Africa. And only half of first children had taken any antiretrovirals. In the next slide, as a finish up, it's just some areas that we've been able to share these preliminary findings and inform programming and some documents. I'm happy to share them for colleagues who are interested. The South African Medical Research Council is designing a social impact bond on adolescent girls and young women. And one of the components is to support adolescent girls living with HIV, better retention and care, and access to contraception and ART. And just a final reminder from all of us in the next slide in our Hey Baby team is that being an adolescent mother, next slide, please. is quite complicated. And some of these complications and difficulties are true for all young mothers. And in many cases, if I'm honest, for all mothers, as my children are currently screaming behind the door where I'm presenting. But there are some areas where being an adolescent mother living with HIV is much worse or more difficult. Despite all of this, the adolescent mothers in our sample were really determined to do the best that they could for themselves and their children. And they asked us for childcare. They wanted to have food security for themselves and their children. And they wanted to be treated with respect and dignity in their facilities. Thank you, everyone.
Thank you so much, Dr. Elona, for a very nice presentation. So right now, let's move to the second speakers, Dr. Sirinya from Thailand. Dr. Sirinya, please.
Hello, everyone.
Yes, please go ahead.
Okay. Hello, everyone. My name is Sirinya Teeraananchai. I would like to talk about my study. Grantee from in 2018. My study is about the evaluation of service delivery to improve the HIV treatment cascades among youth living with HIV in Thailand. Next slide, please. First of all, I would like to brief about the breakout of this study. For the left-hand side, the figure on the left-hand side, I would like to brief about universal health coverage in Thailand. So Thailand offers free HIV testing and treatment to the National AIDS program, which is a part of Universal Health Coverage program. So we also have a national treatment guideline for initiating ART have changed over the program life. In 2009, guidelines suggest to start ART when CD4 count declined to 200 cells per mil. In 2013, the guideline was changed to initiate treatment for patients at CD4 count less than 350. And in 2014, the recommendation was made to start ART regardless of CD4 count. And so we will see that in the right-hand side, we would like to show some the number of patients that we would like to study from the database that we have all information from the National AIDS program. So we look at the adolescent and youth from age 15 to 24 that were increasing in a number of newly HIV-infected youth age 15 to 19 years, and also 20 to 24 years who register in the program. And those of them are most likely behaviorally infected. So this comes to the objective of this study, that we would like to access the characteristic of HIV care and treatment service for youth living with HIV in Thailand, and correlate this with care outcome to gather data on best practice which can be emulated. Next slide, please. And so the study procedure of this study, we classify into two phases. The first phase, we enroll youth aged between 15 to 24 years who register in the NAP between 2008 and 2018. And we also would like to compare the outcome from the two periods. The first period is 2008 to 2013, and the second period is after patient can start at any CD4 count after 2014, 2018. And for the second phase, we enroll just only youth age between 15 and 24 who register after 2014, that after we change the guideline can treat at any CD4 level, and also access the HIV cascade and look at the proportion of the initiation ART and viral load testing and viral suppression after ART initiation. Next slide, please. For the first result, that this one just published in the JIAS in September 2020. We have a total of patients around 51,607 youths that enroll in this period that we classify in two groups for the first period and the second period based on the treatment guideline change can start at any CD4 level. So we will see that from the second period is around 58% enrolled in this period, and the median age of overall around 21 years, and most of them are aged 75% aged 20 and 24 years, and the median duration from register to start ART is around 1.5 months. And we conclude the proportion of study outcome in the first figure on the left-hand side. We will see that from the first period, the number of patients who died decreased from 4% to 2% into the second period. And when we look at the loss of follow-up, they decreased from 17% to 11%. And also when look at the patient can start within same day, increased from 10% to 16% in the second period. And when look at the rapid ART within 7 months, they increased from 14% to 83%. And also when we look at in 1 month, the youth can start ART from 27% and increase to 52%. And also when we look at overall to accessing ART, they increased from 80% to 83%. And also when we look at the right-hand side toward the cumulative incidence of accessing ART over the period, we will see the increasing trend in the second period and in the second period that from at 1 month up increase from 27% to the 52%, and at 12 months increase from 51% increase to 78%. And next slide, please. The next slide show the second result from the phase 2 from the HIV cascade. We classify in the 2 age group between age 15 and 19 in the first group, and also the between 20 and 24 in the second group. So we will find that there were no different among this group. So when we enroll them 100%, and we will see that 86% can start ART, and also 69% can have a viral load testing, and from this 61% has a viral load suppression at viral load less than 200 copies per ml. And we found that it's around 17% that who have no viral load testing. 11% from them lost to follow up, and 2% die, and 4% recently start ART and were not yet eligible for viral load testing, because in Thailand we can test after they start ART after 6 months. Next slide, please. And this is the recent result from the data update. So we will see that 27,695% reaches from 2014 and 2019, and we will find that they increase up to 98% start ART, and a median duration from register to start ART was just only 1 month. And also when we look at the treatment monitoring, we will see that a median frequency of viral load measurement was 1 time per year. A median duration on us was 3 years, and after start ART 4% die and 19% lost to follow up. And we also, when we look at the Gavi, we also are classified based on the region in Thailand. We will see that at the first year of ART initiation, the proportion of viral loads less than 50 copies per ml, most of them is around 65%. And when we look at the viral load suppression at the last visit, we will see at that all region increased more than 70%, and especially in Bangkok and in the northern region. And next slide, please. And for the impact of the CIPHER project on the community, we can access the national HIV survey pattern from the national AIDS program in Thailand, and also we can encourage youth living with HIV to access to care, and also the impact on the policy and practice. And this data we can access to analyze the database from the national AIDS program that can show the result that never seen in anywhere. And also this will be example of the best practice around HIV program and treatment outcome for low and middle income country. And so next slide, please. And I would like to thank you the CIPHER grant 2018 and 2020 from the International AIDS Society and the National Health Security Office that who manage the data from NAT program, and the Ministry of Public Health in Thailand, and the HIV Netherlands Australia Thailand Research Collaboration, or HIV-NAT Thailand Court. Thank you.
Thank you so much, Dr. Sirinya, for the very great jobs and great presentation. Just for the reminder, if you have questions to the speakers, please feel free to send your question to the chat box, and then we will address them after all presentations. So let's move to our last speaker, Dr. Merrian Brooks from Botswana. Dr. Merrian, please.
Hello. All right. I'm Merrian Brooks, and I'm going to talk about my study that is starting now. I just received the CIPHER award with this cohort in May 2020, and with COVID and other things, it's been a slow start. We actually just started this past 2 weeks back. So I'm just going to tell you what the plan is, and I would love any feedback that you all have to offer. So today I'm going to talk to you about this program implementing, which is a key phrase, lay counselor, oh, go ahead, that's fine. Lay counselor based counseling for youth living with HIV and youth at risk for HIV, defined as sexually active youth in a very high prevalence area. So I wanted to first start talking about why I decided on this study in this particular population. So we did some screening initially. My first project in Botswana was really getting to understand what the needs are for adolescents and young adults who have needs, mental health needs. And so we screened a bunch of youth living with HIV and found very high rates of depression and anxiety. I use this picture to illustrate how you by looking at youth who are, what we were doing in Botswana was just looking at youth who had suicidal ideation or suicidal behaviors. And so we were only getting a super small portion of the mental health concerns in the youth living with HIV. And we also wondered if the mental health concerns were actually getting in the way of youth being able to, stay HIV free in the community that I work in. And so we found that in our youth living with HIV, we had rates up to 30% of depression or anxiety symptoms. So it hasn't, they weren't all interviewed by professionals to confirm their diagnoses, but the PHQ-9, which we used, was validated in that group. And so we saw that in the HIV, kids living with or adolescents and young adults living with HIV, that they had rates up to 30%. In our youth who were at risk, so sexually active youth or drug using youth in our vulnerable youth population, we found also very high numbers, up to 20% of youth having at least mild symptoms of depression or anxiety, and about 17% of our youth having at least mild symptoms of depression. And so we thought there's definitely something here. So let's try to actually address the needs. Next slide. So you can do the next slide. Okay. So we were, sorry, go back. I think I'm a little bit behind. So we wanted to understand what goes into mental health seeking behavior for those living with HIV. And so that's why I really emphasized the implementation part. So we have two kind of areas that we're going to address this objective, but really thinking about it holistically, it's really about what gets in the way of or what elements are there to mental health seeking behavior for those adolescents and young adults living with HIV? Is there an element of double stigma, for example? Is HIV related stigma and mental health related stigma playing a role? Does it affect their ability to receive care for HIV? Or mental health, or both? Is there a care seeking fatigue, meaning do they, because they have to go for their HIV related visits, does that make it difficult for them to follow up for mental health related visits? We know that adolescents struggle with logistical barriers to health seeking behavior. And so we wanted to understand what the logistical barriers might be, given that mental health care, especially therapy-based healthcare, requires more of a logistical commitment. And then what beliefs do the young people have about their symptoms and about their needs for mental health care? So we wanted to understand kind of each of those elements. Within each of those, there's obviously a parental component for those who are not living alone. Most of our youth live with some caregiver. So each of these different areas also has a component of how the caregivers, for example, the caregiver's stigma or the caregiver's beliefs or the caregiver's contribution to the logistics. Next slide. So with that sort of overall view, we are taking we're addressing mental health needs through a variety of aims. So the first aim is to understand just the knowledge, attitudes, and practices around mental health seeking. And we had a lot of theories based on some pilot work that we had done trying to understand what interventions would work, that there were stigmas. And so we wanted to know, is there an intersection between the HIV related stigma and mental health seeking behavior related stigma? So that's the first aim, which we'll talk about in more detail. And then we wanted to know about a community-based approach to delivering mental health care, given our preliminary, I'm a physician in Botswana, and so based on my experiences with patients, that's where a lot of our hypotheses come from, and that's also where our experience is providing care in a clinic-based setting. We know that the clinic-based setting has a lot of pros, but we also know that there are some cons. And so we thought, should we explore the safety of providing a community-based lay counselor-focused approach? And if so, what kind of protocols do we need to have in place? And then we wanted to we are going to pilot a community-based approach to a lay counselor-based intervention to address now that once we understand, the mental health seeking behaviors and the needs, we'll place the intervention on top of those needs to see if it will work and if it might help. Next slide. So with aim 1, we are looking at, oh, did I lose? Is it just me that can't see my slides? Oh, okay. So, so we have two sites to our study. One is a clinic that we are recruiting for both the mental health seeking behavior, and for the understanding just generally what the needs are for youth living with HIV. And then some of our youth living with HIV also attend a community center. And we also, our youth who are at risk for HIV also attend the same community center. So our second site is a community center that provides care, provides a whole host of services for youth. And so those are our two settings, and we wanted to be able to compare the answers we get from the clinic-based setting and the answers that we get from the community-based setting. So slide 31, slide, I don't know, after the settings slide, I think it's 33 is the slide I'm on. So for AIM 1, the design of the AIM is a mixed methods approach. So we are doing semi-structured interviews with 15 youth and their caregivers. And so we really wanted to understand just generally, like I mentioned, the knowledge, attitudes, and practices to generate some further hypotheses and to generate some key areas to ask about and explore. And then after we analyze those themes, we're going to create a survey based on the content of the interviews. And then we're going to use both of those to summarize important mental health seeking behavior related to HIV care. And so what we want to use that information for is to really create meaningful feedback to inform not just our intervention, but other interventions that are looking to address HIV, to address mental health care for those living with HIV and those at risk. Next slide. So we wanted to focus on lay counselors and their safety. So you know, there's not a lot of time to go into the origins of all of this, but this is based on the Friendship Bench, which I'm sure many of you have heard about. And I know in the recent workshop for adolescents, there was some data presented regarding the the youth delivery of a lay counselor-based program in Zimbabwe. And that's really what we're looking at. But we wanted to understand what, again, the implementation areas that were most important to delivering that care. And in our preliminary studies, we found that young adult counselors, so we used young adult counselors to work with adolescents, that the young adult counselors felt safe and they felt comfortable when they were working out of a clinic, and then their clients support them and love having them. The clients really, it was night and day. We had one client who celebrated when he realized that his counselor wasn't going to be the in-clinic counselor, but rather somebody he saw as a peer. And then in 50 interactions that we had with our lay counselors and their clients, only 3 were referred for additional assistance, and 2 of those were referred only in the first few weeks of the interaction, because they weren't sure what they can handle, and now they're much more comfortable. Next slide. So so we wanted to really think about the safety and feasibility of a remote counseling supervision program. So as many of you are, I'm sure, are aware, when you do work with lay counselors, there has to be a supervision mechanisms for all kinds of reasons, most of them being ethical. And so we were wondering, is it safe? You know, what technique can we use so that the youth feel supported and like they could do the heavy lifting of being lay counselors? And so we're piloting this use of phone-based supervision. So if you have a problem, you would just call one of us, and we would help guide you through it. And there would be protocols in place to take a young person who's outside of the clinic to a clinic space. So if they need specific help related to suicidal ideation or psychosis or other emergent concerns. Next slide. And so we wanted to make sure that we thought about all the different things that could potentially go on if we're doing more community-based referral, community-based implementation of the lay counselor program. And so some of the outcomes that we were looking at, that we're going to be looking at, are rates of referral for those who are outside the clinic and maybe even outside of the community center, like for example at a school or something like that, or even in a park, which was mentioned by some of our stakeholders. What the feedback from the lay counselors, what feedback we get from clients, and then we're also going to implement observers to provide us with feedback on what they think went well and what didn't go well in our program with lay counselors outside of the clinic, or any structured space that has mental health professionals on board. Next slide. So we basically want to understand to the best of our ability, what does it take to create a safe program that's also effective and well received by young people, and also is something that's efficacious and results in longer term mental health and related adherence and other HIV related outcomes. Next slide. So the last aim is to pilot test community delivery of the mental health services, really related to the delivering a lay counselor based program in community based settings. So we are setting up a relationship with one of the schools to pilot it as a community center, and also in this community center that we already have a relationship with. And so we're just going to do basic measures of efficacy with just a pre and post assessment of symptoms of anxiety or depression. And we also want to know what skills they develop, because we're using problem solving therapy with our lay counselors. So we want to know what skills in problem solving do they develop. And then we also are just doing the nuts and bolts of a pilot, so recruitment, retention, and comparing it to our recruitment and retention at our clinic-based site. Next slide. So one of the things that we noticed is that there, in our previous work, is that retention, first of all, even beyond our own work, but the retention is a big deal in mental health treatment, particularly therapy-based treatment. And so we wanted to include any of the factors that we have from AIM-1 to try to address the retention in our implementation of this intervention. And we want to be able to address whatever specific areas come up from AIM-1 to make sure that we create a program that's responsive to the specific framework that youth are working from in their health-seeking behavior. Next slide. And so I would just like to thank everyone that contributed to getting this grant. So my mentors who have helped guide me, Dr. Lowenthal and my team, the CIPHER and International AIDS Society, and then my employers and my adjunct spot at the University of Botswana and the Botswana UPENN partnership. Thank you.
Thank you so much, Dr. Merrian Brooks, for the very nice and interesting study. I'm looking forward for your results. So I would like to thank all the speakers for the very great jobs and great presentation. And now we are moving to the Q&A session. And we have around 20 minutes for the Q&A. So if you have questions, please feel free to send your question into the chat box. Or if you would like to ask the question directly to the speaker verbally in this room, please raise your hand. Okay, so first of all, I will ask the question. The first question in the chat box is from Dr. Pim Bowers to Dr. Elona Toska. His question is, if you have time data on stockouts, what's your population at higher risk for continued non-adherence? And is that also reflect in the COVID difficulties with clinic access? Dr. Elona, please kindly address these questions.
Yes, thank you, Tavitya, and thank you, Pim, for the question. It's a really useful one to try and disentangle what is making the biggest difference in why the treatment interruptions are happening. From our qualitative work in South Africa, the stockouts are not, people handle stockouts slightly differently. So the part that is missing in that story is also what nurses are doing at that specific and how to handle stockouts. So for example, we hear that nurses often will call their friend who's also a nurse at a nearby clinic and get some medicine for the participants or adolescents and children, and in some ways have this informal system of providing medication. So what we don't have is whether the treatment stockout that the young mothers reported, how long it lasted for. But there may be ways to actually statistically handle that and figure out whether it's the stockout or other factors that are actually shaping the treatment interruption. So thank you for that question.
Okay, thank you so much. I saw the next question from Dr. Natalie for Dr. Brooks. And there's few questions here. So let's begin from the first question, that how do you plan to standardize training for the staff in your study?
Hi, thanks so much for the questions. I am actually going to address a few of these questions at once.
Okay.
Seeing what people say, what they want. Okay, yes, great. Oh, these are all awesome questions. So I'm going to talk about the lay counselors training, confidentiality, and selection. So the selection criteria that we used is, we have used, and that we are going to be using for our next cohort is actually established by stakeholders. So there wasn't any time to talk about what we've done in the past, but the biggest thing that we did was meet with stakeholders over a series of meetings to just to understand what the mental health needs were for youth living with HIV and those who aren't even in the community, their mental health needs. So they actually established the criteria. So we asked them, if we were to make a lay counselor-based program for adolescents, what would you say? They said that it was really important for them to be young because of cultural and generational issues regarding communication. They said that it was important for them to have at least some secondary education. They decided that they should have empathy and leadership skills. And so the people we had them recommended by different programs that exist in the community. So for our community center, we asked the center leadership we gave them those criteria and said, can you recommend to us any particular people who you might think would be great lay counselors within these criteria? And then we train them, and then we actually do a training assessment. So it's both a written and an in-person assessment, like a mock case. And so that's how we find our final group of lay counselors is after they've done the training, which is standardized and based on the friendship benches, psycho education and problem solving therapy based intervention. We basically use their same manual. It just has Botswana instead of Shona. And then we confidentiality is established via the training. So one of the things that is emphasized multiple times during the training is that there has to be confidentiality. And we actually had an issue prior with somebody walking into a session and finding out the person that was referred was a friend of theirs, so we had to switch. So that's how we've been doing it, because they're young adults, they're 19 to 30, which is what our stakeholders asked. And so they're not, unaware of how confidentiality affects them. So they are actually really great at making sure that we maintain a strong sense of confidentiality. And then, like I mentioned, for the training, and then how do you anticipate you will resolve sometimes discrepancies seen between what people say they want and what implementation service use figures say? So that's actually really common in adolescent implementation. And so, there's a few implementation frameworks or adaptation frameworks that we're looking into to formalize the adaptation process a little bit more. And one of them involves the use of professionals in the implementation process. So not just service users, the youth themselves, but actually people who have designed systems and work within systems in Botswana, in mental health, to help us to vet some of the adaptations that we might want to make. And then observer-related bias. So yeah, we wanted to use observers just for the implementation element, and there is probably going to be observer-related bias. I'm really interested to know what you would think, what you would recommend to control for it in this setting. But we wanted to use the observers so that we had a third party, not just two people who have a positive relationship. So the client is going to say everything is great, and the counselor is going to say everything is great. So we wanted to have a third party to be noticing certain things related to safety, particularly. That's why we wanted that. But if you had any ideas on how to control for observer bias in that situation, I'd love to hear about it.
Okay, so I saw, I skipped one question for Dr. Brooks from Emma. She asked about the area that you will be piloting this study.
Oh, so we're doing it in one urban area and one more rural area. We're going to be comparing the two, definitely. Sorry, it's so loud here. It just started raining.
Okay, and next is also the question for Dr. Brooks from Joland. Sorry if I incorrectly pronounced your name. Asking about, given the risk of double stigmatization, how do you believe school settings would impact on engagement between counselors and youth?
Yeah, so that's actually, like, I'm so glad you say that. That's a conversation that I've had many, many, many times. I think you have to be really, really sensitive to confidentiality, and how if somebody's known to be the counselor and you're seen with the counselor, like, how does that affect your ability to engage with your colleagues in the school setting? So that's actually something that we've thought about a lot. We're going to schools because people thought that schools would be a good place, and we sort of talked to them about, how would we deal with the confidentiality issues. And so they were saying, oh, if they work with the guidance counselor or something like that, then it could be helpful. I don't know, to be honest with you, what the youth are going to end up responding to, but I think it was pushed enough by the stakeholders who know this place know the dynamics much better than I do, that I thought it was useful to at least explore in a pilot setting what the youth ended up doing. We may be surprised. They may still be open about it and still seek care from their lay counselors in the school setting, regardless of the stigma or confidentiality issues. But I'm not sure.
Okay, thank you. And the next two questions is for Dr. Sirinya. The first question from Michael asking about what gaps has been identified in ART adherence among the youth in your studies.
Thank you for the question, because this is this database is based on the it's a real life setting practice. It's not just like a research. It's not from the research. So we did not have a adherent data exactly for all patients, for HIV patient, but usually patient has to come to the clinic every 3 months to get the regimen, and also the treatment monitoring for the CD4 at every 6 months, and also viral load testing every year after the first 6 months, every year. And also the first time after start at ART after 6 months for viral load testing, and after that annually for viral load testing. So we did not have about the adherent exactly to check the adherent. So, but when I have some focus on some hospital in Bangkok that they have an adolescent friendly, like an adolescent clinic, and they have a nurse that to remind them to take a medicine. And also I think that they also have a caregiver to remind them as well. But normally most of them, they are growing up, so they know what they have to do in Thailand. And thank you.
Okay, for the next question from Dr. Pim, did the classification for timing of treatment initiation affect the long-term outcomes, such as did the same-day ART initiation resulted in better long-term adherence or clinical outcomes in your study?
Thank you. This is a very good question. That because now we have just got a completed data set in the 2-3 months ago. So this analysis is coming up maybe in the early next year. So I cannot answer this question at the moment. And also we classify the timing of treatment, and we also to look at the long-term outcome as well, but the result is not ready yet. Thank you.
Okay, we're looking forward to that results. Is there any other question from the audience? Or if you would like to ask the speakers verbally, just raise your hand. Okay, I did not see any other questions, and I think it's time. So I would like to thank all of the speakers and participants for this very interactive session, Q&A time, and the session. I think we are now at the end of the session, and I would like to thank all of the speakers. Oh, okay, I saw one question. Yes, please feel free to text in the chat box. Yes, you can speak. Nora, could you please grant the mic to this person?
Hello, can you hear me?
Yes, please go ahead for asking the question.
Yes, I just wanted to ask, I think this was the first presentation, so I can't really correct the name, but it was about PMTCT and the ART among adolescents. So there was data to say that actually some of them are on treatment interruption. Like, so I just wanted to find out, like, what are the main reasons that they would interrupt treatment? Is it that it is planned on medical purposes, or maybe they would just interrupt based on the fact that maybe they have seen that they are doing well, then they would stop treatment? Yeah, thank you so much.
Thank you for that question, Kennedy. I'll jump right in, Chair, if that's okay. There are a couple of reasons, or there are multiple reasons why the interruptions could be happening. Some are, as I mentioned earlier, and following Dr. Brower's question, possibly structural, so the medication not being available. Others are linked to just disengaging from care, so not going to appointments regularly, particularly after the child has been born and they may test negative, for example. And then there's also more sort of cultural, seasonal reasons. A lot of young people in South Africa travel for extended periods of time, often during the holidays or during, so twice a year, to different locations far away. And it's not easy to transfer clinic care because we don't have a unified clinic ID, but it's not purposeful. Treatment holidays are not common. We ask for them and we would report them separately. So this is treatment interruptions that shouldn't have happened. We are testing some other factors, like you mentioned. So substance use came up as quite an important factor, as I mentioned, or not being able to take medication because they have reported substance use. We're looking at whether it's pill burden, but that's less likely because they've started recently and they're actually on single pill medication. And being in difficult relationships. So potentially, we know adolescents, I don't know if any of us remembers relationships when we were adolescents, but they're not really long-term stable spaces where one can take medications in a comforting, supported space. So maybe having a new boyfriend or having a fight with a boyfriend and having to leave the house you're sharing with them or one's partner means that you just don't bring your pills with you or can't take them. So there's actually quite a lot of possible factors, and we're trying to figure out, at least quantitatively in our data, what is the strongest factor, so we can share that with our providers in our study site and hope to adapt services that way. Thank you for your question, Kennedy.
Okay, is there any other question? Okay, so I think it's now at the end of the session, and I would like to thank all of the speakers for their presentations and for staying for the question from the audience, as well as thanks for all of the audience for the very interactive participation in this session. We wish you have a nice evening, afternoon, and day. So thank you so much for joining this session. Bye-bye.